Okay, I think most folks are back. I'm Wayne Sanderson from University of Kentucky, and I'm the director of our ERC and our Ag Center there. I'm just giving a brief overview on South On. This is a conference we really look forward to every year. It's great because I think the size is just about right, and we really created it to be a workshop. I can't tell you how many great ideas, and one from this morning we'll be talking about. Dr. Fletcher's talk in our staff meetings and how that may change the direction of our center and greater collaborations with others. But we've been having South On now for a number of years. I don't even know when the first year was. Terry, do you know when we first created it?
South On is about 10 years.
About 10 years ago. And it's been truly a wonderful collaboration with the other ERCs and the Ag Center. Particularly this year, we want to give a shout out to UNC. We know how much work this is to put these on, and we're grateful to John and Lena and your team, all your team for putting this on. It's a great place. The bar keeps getting higher and higher. We haven't been together since Birmingham in 2020, and that was a great conference. Alan and Claudio and their team did a great job. Next year is Tampa, and then I guess 2 years from now it's back to us in Kentucky. So it circles around. I did want to mention a few things. Glad we're in person, and we do get some funding from NIOSH CDC on this. Dr. Bum was the PI for a number of years. We just got that reawarded in December of this past year. And that means that there's funds available to support this conference. In particular, those funds are meant to be shared with our state colleagues who may not have travel funds to come to this. We really want this to make sure that this just isn't an academic conference of the centers, but it truly involves our partners and the people who are likely to be hiring and recruiting our students, by the way. Give them a showcase with their posters and their presentations. So if you're particularly from a state agency that needs funding, you should talk to Kristen Kane or Ashley Rockwell, who are really kind of manage this grant for us, and we do have funds available to support it. And as I said, we look forward to it every year, particularly being back on UNC's campus. I'm a UNC alumni, so it's great to be back in Chapel Hill. So thank you. With that, I'm going to turn it over to Dr. Bunn. You're going to introduce the next set of panels.
All right, good morning. This panel is going to be looking particularly at, it's our COVID panel, and we have 4 speakers today, so they're each going to speak, and we'll leave questions to the end of the session. So our first speaker this morning is Dr. Paula Arnett. She is the principal investigator of our supplements to our Kentucky Occupational Safety and Health Surveillance Program. She has 2 COVID supplements, one focused on worker safety and health, and the other one focused on well, I'm blanking out, but it is on looking at a COVID-19 survey that she did among long-term care administrators in, the long-term care industry. So I'm very pleased to present Dr. Paula Arnett. She's also the Associate Dean for Administration at the University of Kentucky College of Public Health and a staff associate at our Kentucky Injury Prevention and Research Center. Her expertise lies in organizational policy and process development and evaluation. So welcome, Dr. Arnett.
Thank you, Dr. Bunn. As Dr. Bunn mentioned, we did receive 2 COVID supplements, one of which had a little bit of problems getting off to a good start. Let's just put it that way. I'm going to share my screens. So the first one was vaccine hesitancy in long-term care. This idea came from the liaison to the governor for long-term care facilities in the state of Kentucky. Last summer, he mentioned that the vaccine uptake for this population was less than the national average. We were under 50% for employees that are taking care of our most vulnerable population. This supplement actually was supposed to look at vaccination rates, as well as hesitancy among long-term care employees. There was a slight problem that occurred right after the supplement this proposal was submitted. We submitted it on August the 9th. On August the 18th, the Center for Medicare and Medicaid Services came out with an announcement that all long-term care employees were going to be required to be vaccinated by January the 1st. So our 12-year project went down to about 4 months. And in that time frame, we had to develop the survey, get some partners, develop that relationship, trying to get out to the long-term care employees. We did it in about 3 months. The survey actually launched in November. However, because of this mandate, we got a very limited response rate. There was only 24 that started the survey and 17 actually finished it. It wasn't meant to be. This one wasn't. About 21 of the 23 that finished or started the survey were female. Most had some college or high school equivalents. Most of the questions that we asked, the only way that we were able to do this was using the CDC vaccine hesitancy survey template that they had. Some of these questions came from that. They're about 50% of them, 43% had COVID at some point. We did ask how they knew that. Most had done testing at local health facilities. We asked if they felt that it would be easy to get vaccinated. Most agreed. There was a long list of options here as far as how difficult it would be and what made it difficult. These are the only 4 responses that we received. It's too far away and religious reasons, and then not sure was the other one. The other, as you'll see, the comments that we received were that one was already vaccinated. This was not supposed to go out to already vaccinated individuals. Others were, we had a COVID in the last 90 days, not comfortable with the vaccine as expected. Motivation was one of the key reasons for this survey, and trying to find out what would motivate this population to take the vaccine. The top 3 choices was to protect family and friends, patients, and if it was required by their employer, which it was getting ready to happen anyway. I don't know if anyone knows, but the requirement for the Kentucky and about 6 other states actually had a stay of execution and has not been implemented actually yet. One of the other interesting facts was how much do you trust the public health agencies providing you with your information about the vaccine? 47% didn't trust them at all. However, the next question was, what's your top 3 trusted sources? And CDC was on the top of that list for this survey. Once again, there's nothing statistically significant here because of the limited number of individuals that provided answers to the questions. The other the other project that we received approval for was looking at surveillance of work-related cases. Because of having to push the first project into a shorter time frame, this one has had a little bit of a delay getting off the ground. However, we have done a few things. This is specifically to look at work-related COVID cases within the Commonwealth and how our surveillance is identifying those, or if it's possible to identify those. The first thing that we wanted to look at was syndromic surveillance data. This has been huge in Kentucky for tracking COVID cases, primarily use it to look at ED cases for a lot of drug overdose deaths and things of that. This was the first trial at looking at occupationally related COVID cases in this data set. We looked at March 2020 through June 2021. There were only 361 occupationally identifiable cases in the entire data set during this time frame. There was 4 geographical areas identified. This is Louisville, this is Lexington, and this is Pikeville is here. It's kind of what we expected. It wasn't anything, a lot of this is healthcare related. The locations that were identified were healthcare facilities. These were clinics in Eastern Kentucky that were identified as COVID-related exposures. So that there wasn't a lot of data there, but they did look at all data that they had, including emergency, inpatient, outpatient, primary care, and urgent care data. Only 300 and that says 51. I thought it was 61. The other data that we are looking at is NIOX data, and we have linked it with COVID-related death certificates. There were 9,000 records. We ended up with about 7,000 cases total that we can do some analysis on. That is upcoming. We are working through that now. We are also transcribing the OSHA 36 fatality and catastrophe reports so that we can analyze those to see if we can get any occupational data related to those as well.
Thank you, Dr. Arnett. Our next speaker is Anna Riley. She is an environmental health scientist, epidemiologist at the Louisiana Department of Health, Office of Public Health, Section of Environmental Epidemiology and Toxicology. She serves as the PI of the Louisiana Occupational Health and Injury Surveillance Program, which is funded through a NIOSH cooperative agreement. She earned her MPH in epidemiology and PhD in pharmacology from the Louisiana State University Health Science Center in New Orleans. And in 2021, the Louisiana Occupational Health Program became an expanded program by launching an occupational health-related illness prevention program and by becoming the 8th Fatality Assessment and Control Evaluation State. Other current program work includes workplace homicides and the analysis of fatal opioid overdoses, and she'll be talking this morning about the COVID fatalities by industry and occupation.
All right, so today I'm going to be talking about COVID-19 and the Louisiana workforce. So before I get started on our projects, I wanted to talk briefly about some of the resources and data that LDH as an agency has made available on its COVID-19 information webpage. Under the Guidance and Resources tab, businesses can find COVID-19 related information under the Other Resources tab, and I have that marked here under the red arrows. And there's information such as return to work information and Open Safely guidance for businesses. The Open Safely program is a web-based program that was activated by the Louisiana Fire Marshal's Office in collaboration with LDH in May of 2020 to assist businesses and religious organizations with safely resuming operations during the pandemic. On this page, there's also some workplace-specific information from the CDC, such as best practices for retail stores, restaurants, and food pickup and delivery services, cleaning and disinfecting of food establishments and other businesses, and decision-making tools. Under the COVID-19 data tab, which I have marked with the yellow arrow, is the COVID data and vaccination dashboards, neither of which contain any work-related data. And you can also find the institution or college level data page and the COVID outbreak data page. The COVID outbreak data page does report workplace as a setting, and I'll discuss this more in a few minutes. There are several occupational the Occupational Health Program has started work on or planned several COVID-related projects. And these projects involve mortality data, outbreak data, contact tracing data, workers' compensation claim data, and developing targeted guidance for employers and employees. And I'll briefly describe where we are with each of these projects at this time. So COVID-19 fatalities among Louisiana workers in 2020. This analysis of COVID-related deaths among Louisiana workers is currently being done by an MPH practicum student, Rashonda Littles. We selected death certificate records of Louisiana residents aged 18 to 70 with an ICD-10 code of U70.1 listed as a primary or secondary cause of death. The data set was then linked with NIOSH's occupational mortality surveillance data so that the free text industry and occupation fields and the death records could be coded into NAICS sectors and SOC groups. The records were then removed from the data set if the industry and or occupation code was indicative of not being in the workforce, retired, or disabled. Demographic variables were collected, including age, sex, race, ethnicity, and education level. And then Shanda calculated rates and rate ratios to make comparisons, and she plans to characterize the distribution of risk level of exposure among non-healthcare occupations using the SARS-CoV-2 occupational exposure matrix. So here is some of Shanda's data so far. The rate of COVID-related mortality increases with age. The two oldest age groups had a mortality rate that was significantly higher than the mortality rate for all workers. On the right, only Black workers had a mortality rate that was significantly higher than the rate for all workers. The other races, almost all of the other races had a rate that was significantly lower than all workers. And then interestingly, in Louisiana, Hispanic workers had a significantly lower COVID-related mortality rate than the COVID mortality rate for all workers. Here is by education level. So the higher the education level, the lower the COVID-related mortality rate among Louisiana workers. Decedents with a high school diploma or less had a significantly higher rate of COVID-related mortality than the rate for all workers. And then these two graphs represent the industry sectors and occupational groups with COVID-related mortality rates significantly higher than the COVID-related mortality rate for all workers. The top three industry sectors were transportation and warehousing, followed by agriculture, forestry, fishing and hunting, and mining, quarrying, and oil and gas extraction. The top three occupational groups were farming, fishing, and forestry, transportation and material moving, and protective services. The next projects involve contact tracing data and outbreak data. Both of these data sets are owned by Infectious Disease Epidemiology Program, or IDEPI. And the idea behind utilizing these two data sources is to examine COVID-related morbidity rather than mortality. So to kind of compare these two data sources, contact tracing data, like most states, contact tracing data collection efforts haven't been as effective as initially hoped for. And at times of peak infection rates, interviewers have been capturing less than 5% of cases. Outbreaks are actually discovered in 3 different ways, either through contact tracing interviews, from a facility calling in to report an outbreak as they're asking IDEPI for guidance on mitigation measures, or by concerned citizen complaints, such as someone noticing an employee of a business working while seemingly sick. Contact tracing data is somewhat of a richer data source than outbreak data in terms of the amount of information that is collected, but both of these data sources do collect basic demographic information such as age, gender, race, and ethnicity. Contact tracing data only captures the occupation, and outbreak data captures the name of the facility and the person's position, such as student, staff, resident, or other. IDEPI staff have been assigning a setting to outbreak data based on the business name. So with outbreak data, we can identify if the person was a worker or not, and through some additional work, we can determine the industry using the company name. With contact tracing data, we only have occupation, assuming that this field gets completed. So this is a screenshot of LDH's COVID outbreak data webpage. The ID epidemiologist, Julius Tonstel, who oversees the outbreak data webpage, has expressed interest to us in applying NAICS code to the workplace data, which is this last category at the bottom. So because of this, together with the other factors that I just talked about in this last slide, we decided to go ahead and work with outbreak data next. And we're currently working with Mr. Tonstel to add industry data to this outbreak data through the use of NIOX. And we expect to have this updated data within the next week or so. And we'll be able to start our examination of the outbreak data. And we plan to do that similarly to how we're analyzing the mortality data. And after we complete that, then we'll revisit the contact tracing data analysis. The occupational program staff is also participating in the NIOSH COVID-19 Workers' Compensation Work Group with staff from the Louisiana Office of Workers' Compensation Administration. And the purpose of this work group is to collaborate with states to analyze workers' compensation claims data related to COVID-19. So staff members from both of these programs have worked together to produce a presentation titled Office of Workers' Compensation 2020 COVID-19 Filed Claims versus Accepted Claims by Industry and Occupation. Unfortunately, this is still undergoing internal review, so I don't have any results to present today. But we're also in the process of writing up a brief report of the results, and hopefully we'll be able to share that soon. And then finally, we also have some COVID-19 supplemental funds, but we've had some delays in getting this project launched for several reasons, including staffing issues, contract delays, and COVID itself has sort of delayed getting this off the ground. But to summarize, the overall aims of this funding are to measure the burden of COVID-19 outbreaks and associated cases in occupational settings. Outbreak data analysis that we've just previously discussed will serve as the basis for this aim and will be used to inform aim 2, which is to develop guidance for employers and employees, especially in the most impacted employment sectors. And finally, aim 3 of this funding is to provide additional support to SEAT to assist in our response to requests for guidance associated with the COVID-19 pandemic. So our FACE investigator is an industrial hygienist, and he's going to be the one that's going to be assisting with aim 2 and 3 specifically with these COVID supplemental funds. And that is all I have. So if we have any questions, I understand we'll wait till the end, but that's all I have. Thank you.
Our next panel speaker is Rana Bayakli, who received her bachelor's degree in biological sciences from Boston University and a master's in public health from Tulane University. She started her career as an epidemiologist at the Louisiana Office of Public Health, and then she moved to Atlanta in 1996 when she was employed as the director of the Georgia Comprehensive Cancer Registry. And since then, she's served in various roles within the Georgia Department for Public Health. In 2011, she was promoted to chief epidemiologist for the Chronic Disease, Health Behaviors, and Injury Epi section. And in this role, she oversees several chronic disease registries, health behavior surveys, and occupational health surveillance. Ms. Bayakli's focus is on collecting, monitoring, analyzing, and disseminating public health surveillance data. She works closely with various partners and organizations to effectively use public health data as well. She's actively engaged in statewide steering committees, coalitions, and task force related to chronic disease, occupational health, and injury, focused on improving healthcare delivery and implementation of evidence-based prevention and intervention programs. So welcome, Rana.
Good morning, everyone, and thank you for inviting me to speak on our Georgia Occupation Health Surveillance program or activities. I am speaking on behalf of Antoinette Lavender, who is our occupational health epidemiologist and lead for our surveillance system related to occupational health. She was unable to attend this meeting, and she shares her apologies. She is currently on maternity leave, and she'll be back in May of this year. So she helped me with these slides. So I just wanted to thank her for preparing some of these slides as she's highly engaged and I'm mainly overseeing her work. In June of 2021, Georgia became a Fundamental Plus program. So we received additional fund to do a little bit more work on our occupation surveillance. In general, our fundamental aims are to really collect, analyze, and disseminate our occupation health indicators. And we have 3 more indicators that are state-specific related to secondhand smoke, arthritis, and violent deaths, work-related violent deaths. We also work on, based on the occupation health indicators analysis, we identify priority indicators and do more in-depth analysis. And through the years, transportation, pesticide, and with 2020, COVID became our priorities. We have a couple of follow back investigation program, one of which is our blood level among follow back on adult with high blood level lead levels data or information. And that's based on our lab data that our environmental health receive, and they share the data with us, and collaboratively we would work with industries that have a high number of employees with elevated blood lead levels. For our Fundamental Plus project, and we're just starting with the workplace suicide, we are working with OSHA on creating our alliance, and we actually have a set date for signing our alliance, which is April of this year. As well as working with our governor, respiratory disease council. So hoping to create policies and intervention related to asthma and other occupational respiratory diseases. In June of 2021 or July of 2021, we received 2 additional supplemental funding focused on work safety and health. And the second one is the vaccine task force. In the work safety and health program, the purpose of it is really to help in creating policies to reduce and prevent COVID-19 outbreaks. So the program tasked to create the tools as well as work with an organization that is currently providing mobile vaccine units and making it specifically working at work site with high exposure of COVID-19. The second supplemental funding purpose is really to reduce the hesitancy among workers, especially in areas of low vaccination rate and industries that seem to have low vaccination rate in Georgia. So what Antoinette and her team done, first she analyzed our COVID-19 data for those who confirmed or probable, and those who work outside the home from March 2020 to April 2021. We actually access our COVID-19 data. We have full access to our COVID-19 data. So Antoinette is able to analyze the data as she has good access. And in the beginning of the COVID-19 epidemic, she was able to add industry and occupation on our contact tracing and outbreak investigations. So based on her analysis, you see that, healthcare, these are the top leading industries that had high exposure of COVID for their workers who work outside their home between that period. For us and in this program, we focused on, other than healthcare, specifically on education and manufacturing. That's technically this list our targeted industries for our COVID or WSH, worker safety and health supplemental funding. We've decided to focus on education, manufacturing, and agriculture. In education, we wanted to go broader than just teachers and administrative staff. We wanted to reach our auxiliary staff. We also, based in the manufacturing, and the data shows that industries like animal slaughtering, processing, and our carpet and rug mills industries have high exposures. And we have almost 77,000 Georgian that work in agriculture and forestry industry. And we have thousands and thousands of migrant workers who come seasonally and work in the state of Georgia for a short period of time. In Georgia, we are divided into 18 public health districts. I'm not sure if you see my cursor, but those regions that when we analyze the data and show the areas with high exposure and low vaccination rate tend to be the north, northeast, and north central, or what we call public health district 1, 2, and public health district 2, as well as in the southeast, south central, and southwest Georgia, or public health district 8-2, 8-1, and 9-2. This area is predominantly rural area and high population of African American population, while in the northeast, and north central is also rural area, but predominantly white and Hispanic population. What is our worker safety and health program? We have worked with a mobile unit that we call Core Georgia. We have added to the existing contract funding in order to have 25 COVID events or COVID vaccination events at the work site. And they started as of January 1st, from January 1st to June 30th of 2022. Technically, we will reach out to our professional associations, asking them for sponsoring event, helping them to identify industries in those areas, high population areas, high exposure population areas, and low vaccination. And then our vaccination mobile unit will go park in the parking lot at that work site and provide the vaccines for employees that are willing to get vaccinated. We also share our COVID-19 resource toolkit. Antoinette and her team created a toolkit describing COVID, providing all the national resources available and local resources, as well as have posters that the employer can put and post in the work site to remind their workers about social distancing, wearing masks, and the importance of having vaccination. So technically, and as of Friday, looking to see if our areas is still, our targeted areas still have high activity of COVID. Does that really help us in going to the work sites? You can see the yellow and the orange are still in the areas where we have been focusing on. That is the southeast. This is south central, where this orange high activity going on, and this is the southwest. Technically, our epidemic started in this area. This is our main area when the pandemic started, where you could hear Georgia having to move from a hospital that is located in this county to moving patient to parking lot and to a stadium in order to be able to support them. The next effort is our vaccination task force, and we have collaborated with our communication office and created multiple media messages. We had radio spots that really targeted for farmers, more than 58 radio stations in our communication office have done the research looking at those who farmers listen to. We have digital banners that goes on gas pump in those areas that remind, as you are putting gas in your truck, remind them about COVID vaccination, where they can get COVID vaccination. We had TV commercial and we had social media. So this is kind of the radio spot that.
You guys can't hear that, can you? Rana, can you hear me?
Yes.
The audio is not working too well on that.
Okay, that's
Sorry.
okay. But technically, we have Facebook messages, we have Twitter messages, we have these banners. We went to stadiums where the Bulldogs were playing, to baseball games, and send messages as much as possible in both English and Spanish. Looking at more recent vaccination, you can see that those areas has a very low vaccination rate in Georgia, even though overall Georgia is at 56%, this area had really low vaccination rate. The last thing we're doing is funding that we receive through our epidemiology and laboratory capacity. We are adding occupation and industry on our notifiable disease, as well as on our outbreak investigation. So from now, once this industry and occupation fields are implemented as part of the demographic, so therefore we'll go to all notifiable disease, we will be able to analyze the data on a routine basis. And this is what I have. Thank you so much. And we'll take question at the end.
And this is a reminder to all of the speakers, if you are not currently speaking, please mute your microphone. Our next speaker is Dr. Kim Getz, who is the Epidemiology Supervisor with the Occupational and Environmental Epi Branch at the North Carolina Division of Public Health. She leads a team of chemical, occupational, and climate epidemiologists and manages data for the NC Adult Blood Lead Epidemiology and Surveillance Program. She's also currently the interim PI of the NIOSH-funded State Occupational Health Surveillance Program, an epidemiology and laboratory capacity grant to improve the collection of industry and occupation data in COVID-19 case investigations. She also manages the NC Environmental Health Data Dashboard Project, an initiative to create environmental health data visualizations that are accessible to the public, inform public health decisions to increase health equity, and support community resilience and environmental justice initiatives throughout the state. She's worked with the childhood lead poisoning program in the past, and she has also collaborated with local, state, and federal partners to conduct occupational lead exposure cluster investigations and investigate lead in spices, herbal remedies, and ceremonial powders in North Carolina. She earned her undergraduate degree from UNC Chapel Hill and was PI of the Free to Breathe, Free to Teach study of teachers' respiratory health and indoor air quality. Welcome, Dr. Getz.
Thank you very much, and thank you for that introduction. I'm going to go ahead and share my screen here, and I appreciate you all inviting me here. As she said, I am the interim PI currently for the Occupational Health Surveillance Program. So I would like to give a special shout out to the previous PI, Dr. Giolana Dang, who started most of these projects off. And so I'm just continuing on the good work that they did. So just a little bit of background first about the workforce in North Carolina. So we largely have a huge manufacturing, agricultural, and meat processing workforce in North Carolina. We have thousands of workers in some facilities, and one facility that we worked with, which was a meat processing plant, had up to 43 different languages for their employees. So education and outreach has been especially important in these essential worker groups. As you all know, the COVID-19 pandemic has really highlighted the importance of collecting occupational health information, and it has exacerbated existing health and socioeconomic disparities between those who are deemed essential workers and those who are higher paid workers able to work remotely. Due to the nature of their work, including in meat processing plants, essential workers have had to report to the workplace, of course, even through lockdown. And so the workplace has been a primary place of exposure for many people. And this is just one of the news headlines that we had at the beginning of the pandemic. So fairly early on, we realized that this was a key topic. This is the familiar hierarchy of control. So just kind of to overview, of course, essential workers are at increased risk of exposure in meat processing facilities, especially there's an inability to socially distance. Same thing in other manufacturing facilities as well. Sometimes there's insufficient protective equipment, job instability, and a culture of non-adherence in the workplace for infection prevention. But it also offered us an opportunity both for outreach on the importance of occupational health to infection prevention, and also the importance of being able to control work-related exposures and how that is an opportunity for some targeted interventions and policies. So we did not actually apply for the COVID-19 supplemental funds because we already had, as she mentioned, the ELC project focusing on enhancing industry and occupation data collection, and also we had industry and occupation callback survey, as well as our existing outreach to some of these essential businesses. So we did add standard industry and occupation questions into our COVID-19 surveillance system fairly early on in the pandemic, which we were really lucky to be able to do. We were only able to provide a brief training to the local health department. So we're really thankful for funding to be able to go back and develop a full curriculum in how to collect the data and using standard questions such as what is your occupation, what is your employer name, and then what kind of business or industry do you typically work? And those are the NIOSH standard questions. So I'll just go through several of our different projects quickly. The first one, which we did fairly early on, was the COVID-19 workplace exposure callback survey. And we used the survey pilot instrument that NIOSH and several of the states, including North Carolina, contributed to the development of. Let me move this. There we go. So we called 551 residents with confirmed COVID-19 between February 15th, 2021 to July 15th, 2021. Those who were eligible included all non-healthcare workers who were of working age, standard working age, 18 to 64, who worked outside the home 2 weeks prior to being infected with COVID-19. We only had 76 who consented to participate for various reasons. One feedback that we heard from many cases was, we've already talked to you, you meaning the health department in general. Of course, we're actually a different branch of the health department than the ones who call to do case investigation, but the feedback was, we've already heard from the state, we've already answered questions. We don't want to answer any more questions. So that was a typical bit of feedback among those who did not consent to participate. Out of those who consented, we had 73 who were eligible, and you can see the full survey results on our website at our COVID dashboard, but I'll just go over some of the key areas that we saw for improvement in the workplace. So number one was related to actually people coming to work sick. Only 14.7% of employees said their workplace screened customers and clients for symptoms, and only around 60% said their workplace screened employees for symptoms. Most importantly, and especially from a policy level, less than a quarter of employees stated that they received paid time off for their illness, and most of the workers missed an average of 9.5 work days due to feeling ill with COVID. 5 workers admitted to working outside of their home during the 10-day isolation period after experiencing symptoms or testing positive for COVID-19. And typically this was because they did not have leave and just had to go back to maintain their jobs. The number of people were in close contact with either coworkers or other individuals at their job who they knew or thought that they knew that they had COVID-19. Other opportunities for prevention was a little over a quarter of employees said that they received special COVID-19 training in the workplace. Most employees were required to wear a face covering at work, but only a little over a third of employees were actually provided with any kind of face covering by their employer. So what that means is, of course, the quality of the face covering may have varied, and also the compliance may have varied as well, and the cleanliness of the face covering. 68% of respondents said that all of their coworkers wore a face covering when within 6 feet of them, but only about half said that all of the customers and clients and visitors wore a face covering when within 6 feet of them. So, seemingly workplaces were fairly good at enforcing face coverings among their employees, however, a little more hesitant to enforce it among clients and visitors. And 72% of the employees said that their employer required customers and clients to wear a face covering, but obviously this didn't always happen. So now I'm going to go over our occupational COVID-19 cluster weekly reports. And as I said, fairly early on in the pandemic, we were able to add these industry and occupation fields, which was great, and which allowed us to track COVID-19 occupational clusters. And we were able to form several cluster workforces. So we had a special one for agricultural clusters, meat packing, and meat processing facilities, and also correctional facilities, as well as educational and healthcare facility cluster workforces. And so those were groups of employees dedicated to working on these clusters. So this is the total number of occupational clusters and cases by week from March 2020 to February 2022. We started implementing and really educating about collection of that data in April, and you can see right around then we had a fairly large spike in cases. Not the total clusters. The reason for this is because a lot of these clusters on this side of the pandemic were related to meat processing facilities that had a very large workforce. And so those were lots of cases per facility,
Dr. Getz,
basically, per cluster.
Sorry to interrupt, just a time check real quick. You have about 30 seconds, and then we're going to wrap
Oh,
up
okay,
with questions. Thanks.
Thank you so much. Okay. This slide just shows that most of the cases were essential workers. Early on, meat processing facilities were the largest source of cases, and now it's more government services, which include firemen and police officers and EMS workers. We also analyzed the completeness of data. Industry and occupation were largely missing, so this is not collected very often by case investigators, so we are working on that now with our current projects, and we're going to be doing virtual training sessions with COVID-19 case investigators and contact tracers to try to improve this data collection. And I'd like to acknowledge all of the many staff that worked on this, and as well as our funding sources. And now I will hand it over for questions. Thank you all.
We have time for 2 questions from the audience.
Yeah, thanks. So, I mean, obviously, vaccine hesitancy is a major issue, and but it predates the COVID pandemic, and one common illness is influenza, and the U.S. influenza vaccination rates are low historically. They're low in specific industries. They're low to include healthcare workers. And then you have the issue with reluctance of parents to go through the whole childhood vaccination regimens. So, I mean, I was very happy to see all this information and data, but I wonder if it's part of just a larger problem that, and then if your studies, maybe perhaps this question is for Anna, did you consider, or I'm sorry, for Paula, did you consider asking what the participants' perspectives were on other vaccinations? I mean, obviously, just the amount of news in the COVID means that people have a higher perception of the risk associated with it, a much lower perception, perhaps individually, the risk associated with influenza. But overall, I mean, it's all vaccine hesitancy, and if they would have, their overall perceptions on vaccines, and is COVID reluctance, is it similar to influenza reluctance, or are there different perspectives or different considerations at play in an individual?
So since that was directed at me, we did not specifically ask about other vaccines. Since this was long-term care facilities, most of them are already requiring influenza vaccines annually. Most of them require a vaccine status for the individuals to work in the facility. So COVID-19 seems to be a little bit less than what is already required. So we didn't ask about other vaccinations in our surveys.
We have a historically marginalized populations work group, and along those lines, we're trying to work to improve vaccination rates among these populations. And we are finding that it's definitely, there are different reasons in Western North Carolina, which is more interested in like natural medicine, versus in Eastern North Carolina, which the reason is typically more distrust of government. And so, we haven't been able to do a systematic study of vaccine hesitancy in our state, but just from hearing from different community groups about what is driving hesitancy among community members, it's definitely some of the same factors that drives hesitancy among the influenza vaccine